We're going to take 4 pictures of a knee. So the first one we're going to do is an AP. So we're going to collimate down to a 10 by 12 light field. We're going to center a 1/2 inch below the apex of the patella. So here's the patella, this is the apex, and the 1/2 inch is just a little bit below that. We're going to rotate the leg in 3 to 5 degrees. So what we're trying to do is get the tibial plateau parallel with the IR. And a patient like this, we can basically shoot a perpendicular central ray. So that would be a good AP of the knee. Next thing we're going to do is a medial oblique. So it's going to be 45-degree medial oblique. So we're going to roll the patient in. Sometimes you have to roll them up onto their left hip. So just roll up onto your left hip a little bit. That's fine. Your knee goes way in. We're still going to center a 1/2 inch below the apex of the patella. And what we're going to see on this, and this is a common view because we can see the fibula head and neck free from superimposition. That's often a fracture of the knee joint or the proximal tibia. That's a 45-degree medial oblique. Also, we see everything basically on the lateral side. So we see the condyles, epicondyles of the tibia, of the femur, and of the tibia. Next we're going to do is a lateral oblique or external oblique. Same thing, it's going to be a 45-degree rotation. Still going to center a 1/2 inch below the apex of the patella. And on this view, we basically see everything that's on the medial side. So the condyle of the tibia, and condyle of the femur, and epicondyle of the femur. Next we're going to do is a lateral. So we're doing a lateral in the bucky. We're shooting medial lateral. First thing we're going to do is angle the IR, the CR rather, 5 to 7 degrees cephalad. The reason we do that because the medial condyle is more inferior than the lateral condyle. So this is going to make them superimpose. We're going to bring that knee all the way down to the table. And we're going to feel for those condyles to make sure they're perpendicular to the IR. And still going to center a 1/2 inch below the apex of the patella. Make sure you have light all the way around it. You have to open it up just a little bit more, just to make sure that this is on. So that's a good lateral of the knee. Sometimes we have to bring this leg across. If the patient can't get their knee all the way down, she could, but just in case they can't, you can bring this all the way down. And bring that leg across. That helps them actually have better contact with the IR, but the condyles have to maintain that they're perpendicular to the IR.